Dear colleagues, thank you so much for the invitation to speak about the European Thyroid Association Guidelines for Pediatric thyroid nodules and thyroid carcinoma. My name is Hanneke van Santen. I'm the chair of the European Thyroid Association Guideline, and today I will be speaking on behalf of the ETA working group. So I'm a pediatric endocrinologist, clinical scientist, working at the Wilhelmina Children's Hospital, University Medical Center in Utrecht. And as you can see by this bridge, we are connected to the Princess Màxima Center for Pediatric Oncology, where I also work. And in this center, all children with cancer are centralized in Holland since 2018. So I will tell you for the coming minutes on the working group and the methods, on the ETA recommendations, and about our future plans. We started with the ETA working group in September 2019, and I was very happy to be helped by such great colleagues. And as you can see, we are representing a lot of countries in Europe, and all specialists involved in the care for children with thyroid cancer are involved, such as the endocrinology, the surgery, clinical genetics, nuclear medicine, pathology, and of course I'm also very happy that Dr. Takano from Japan wanted to help us with this recommendation, making this not only a European recommendation, but also with input from Japan. First, we divided ourselves into 3 working groups. The first working group is about diagnostics and staging, the second about the treatment, and the third regards to follow-up. We decided to use the American Thyroid Association guideline, written in 2015, as framework for our European recommendation. First, we identified areas of discordance, and secondly, we defined clinical questions for which we want to make literature searches. In total, we made 23 clinical questions. We looked into the literature and made PubMed searches, and we found more than 3,000 studies, of which we could include 45 papers. We graded these papers by the grade system, varying from low-quality papers to high-quality papers. For these recommendations, we first collected the evidence, and then we combined this evidence with our expert opinions, and these two combined led to the consensus of the expert panel members. These consensus were then graded for the strength of the recommendations, varying from strong recommendation, and then we say we recommend, to weak recommendation, and then we will say we suggest. A strong recommendation can be a recommendation for which there's a lot of good solid evidence, and a weak recommendation is a recommendation either where there was little consensus or there was little evidence. The target population for our recommendation are children, so the patients below 18 years of age, presenting with a thyroid nodule or differentiated thyroid cancer. Important to emphasize is why did we want to make special pediatric recommendations? Thyroid cancer in a child is not the same as thyroid cancer in an adult. A child is not a small adult. Thyroid cancer in children has a different presentation, with more often metastasis. It has different genetics, and also the late effects of treatment for thyroid cancer can be more important for the developing child than for an adult. So for all these reasons, we do need special recommendations for children and for adults. So the 2022 European Thyroid Association recommendations have just been published, and you can find the reference here in the European Thyroid Journal of October. The first section in the recommendations is about thyroid nodules, and we addressed the diagnostic dilemma, how to discover the nodule that's malignant while avoiding overdiagnosis or overtreatment. And I know this is also a very important discussion in Japan, and we all know that the more ultrasounds you make, the more nodules you will find. But the question is this clinical significant? You do want to find the malignant nodules, but we do not want to detect all the benign nodules. So we searched the literature for the prevalence of benign nodules in a child, and this is about 0.5 to 2%, which of course depends on the screening methods and on the definition that are used. It's important to realize that the risk of malignancy in a child is much greater than in an adult. The risk of malignancy in a child, in a nodule, is 20 to 25%. Here you can find the diagnostic algorithm that we made to discover the malignant nodule while avoiding overdiagnosis or treatment. And we in fact designed a 2-gatekeeper way. The first gatekeeper is the ultrasound, and it's important to emphasize that it should be an experienced thyroid ultrasonographist in children to really assess the nodule, but also the cervical lymph nodes. If a nodule is confirmed, and it's a suspicious nodule, we recommend fine needle biopsy or fine needle aspiration cytology to classify the Bethesda classification. If thyroid cancer has been proven, then the next step is surgery. We question, should we do hemithyroidectomy or total thyroidectomy? Total thyroidectomy, of course, may be associated with more recurrence-free survival and disease-free survival, but for the low-risk patient, you may wonder if less extensive surgery may be enough. Research literature, but studies for this are lacking. Here you can find the algorithm we defined for thyroid surgery. So we recommended that all children should have a total thyroidectomy. An exception can be made for those children diagnosed operatively after lobectomy with low risk. In those children, you may choose, after discussion with your multidisciplinary board, to do active surveillance. After total thyroidectomy, there should also be, or during total thyroidectomy I should say, there should also be therapeutic bilateral central nerve dissection or lateral nerve dissection if indicated. We do not recommend a prophylactic bilateral central nerve dissection. And this is important because this is different than the American recommendation for children with thyroid cancer. The prophylactic bilateral central nerve dissection has been shown to increase disease-free survival, and it reduces the risk for reoperation. However, a prophylactic central nerve dissection can lead to more children with hypoparathyroidism or children with recurrent nerve injury. If we look at the figures of children with thyroid cancer, we see an excellent survival, but 25 to 30% of them having late effects such as hypoparathyroidism and recurrent nerve injury. So in this recommendation, we aim not to increase survival because it's already so good, but we aim to increase quality of survival, that is, decreasing the number of children with hypoparathyroidism or recurrent nerve injury. And it's for that reason that we do not recommend prophylactic bilateral central nerve dissection. We feel that prophylactic central nerve dissection should only be performed in advanced pediatric thyroid cancer, and it can be avoided or limited to ipsilateral lymphadenectomy in patients without suspicious features for advanced thyroid cancer on neck ultrasound. So what are the indications for postoperative radioactive iodine? Which patients should have iodine, and is there a group of patients that you do not need to treat with radioactive iodine? So we searched literature, but we could not find any specific histopathological criteria related to lymph node metastasis and or distant metastasis. So this is in fact a risk-benefit evaluation, and you may decide on shared decision-making. However, we recommend radioactive iodine for all children following total thyroidectomy. This will remove all remnant thyroid tissue, and it will also enable you to follow your thyroglobulin during follow-up. The activity is an individual-based, patient-based approach in which you, of course, have to balance optimal activity versus the potential side effects. After radioactive iodine, we give levothyroxine to restore euthyroidism, which of course is very important for the growing and developing child. We strive for TSH suppression until full clinical remission has been achieved. After full clinical remission has been achieved, after the first year of treatment, you can let the TSH come up a little bit until a maximum of 1 milliunits per liter. The reason to not want to suppress TSH for prolonged time in low-risk patients or medium-risk patients is because hyperthyroidism also has its negative effects in childhood on bone development, growth, concentration, and activity. We recommend measurement of TSH and free T4 during growth and puberty every 6 months and after puberty once a year. In the follow-up, we do recommend to do imaging by neck ultrasound yearly, the first 5 years of follow-up, but for low-risk patients, we only advise this when TG is rising or TG antibodies are present, or of course, if there's a suspicion of recurrence of disease. And the reason that we will not be too aggressive with the ultrasound is because we want to avoid false positive findings. Again, the more ultrasounds you do, the more you will find, and this will lead to unnecessary overdiagnostics. So this is our algorithm for follow-up for levothyroxine therapy. You aim with your TSH to be lowered, and then you follow your thyroglobulin and your thyroglobulin antibodies. If these are undetectable, you continue your follow-up. In low-risk patients, in the non-low-risk patients, you will also continue your follow-up, but then you will also do the neck ultrasound. If in case of TG detectable but not rising, you will do a neck ultrasound. If this is negative, you may consider a 123 iodine scan, and if it's positive, of course, you will do a fine needle biopsy. In case of high detectable and a rising TG, you will do a neck ultrasound, and if this is negative, then you may also consider 123 iodine or FDG PET scan. If this is also negative, this would be the only case in which we recommend empiric radioactive iodine treatment, because with a high detectable or rising thyroglobulin, there will be thyroid cancer. So the take-home messages are that the children with a thyroid nodule or differentiated thyroid cancer require expert care in an experienced center, and this should be a center in which childhood differentiated thyroid cancer is a disease that's frequently seen, and not just be an adult thyroid cancer center, because thyroid cancer in a child is different than that in adults. Taking the excellent prognosis of pediatric DTC into account, it's of great importance to be aware of and to minimize the adverse effects of treatment. And finally, registries should lead to growing knowledge and finally result in standardization. So now the recommendation is finished, we will move on towards the first European registry for pediatric differentiated thyroid cancer. And this registry will be a component of the wider European registries for rare endocrine conditions, called EURECA. And for this, we have formed a multidisciplinary expert working group, and the registry will be an umbrella type registry with a detailed basic data set, which will help us to have the numbers on prevalence and outcomes, but also for future research. Here you see a big list of all the people already consented to working with us on the consortium, so we are really happy with this. And we hope to have the registry in the future, and I hope to tell you more about it in the coming years. So thank you so much for the invitation. It was really an honor to be able to talk on the Japanese conference, although I'm not there live. I'm there online, and maybe in future meetings I will have the chance to travel to Japan. And of course, you are also very welcome to travel to Holland. And I do really believe that by collaboration, we will improve outcome of children with differentiated thyroid cancer. And lastly, I want to give a big thanks to my working group, who have worked really, really hard the last years to make this recommendation come to this publication. Thank you so much.